Kids don't always have obvious symptoms. So whether it's a tongue tie, a lip tie, or even this new kind of thing we're looking at, buccal ties, you have to think of it as, why does it matter? You have to address all the three components: structure, function, and behavior, and then you're going to address the problem. So if we only do surgery, we're not necessarily helping function and behavior. I will say though, unaddressed myofunctional issues for decades, they don't go away. So, treating it when you're 30 is much better than waiting until you're 50. But when you're a kid, that's where you really have the opportunity to not just change the function, but also the structure through guiding growth.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, the dental podcast. This is episode number 318, and I am your host, Andrew Johnston. Thank you for letting us be a part of your day. We, of course, have another great episode planned for you today. We have the Sarah Hornsby on. This is an episode that was recorded last month with Michelle, and so you know it's going to be good. I actually completely forgot to read one of our recent reviews last week, so sorry about that. But there's no time like the present to fix this, so here we go. This comes from Apple. It's an Apple review. It's 5 stars from Talia Strain. And she says, it's titled Great Podcast. I have been listening to this podcast for a few years. I love the extra information I get each week. Great refreshers and new material constantly flowing in. I love I get a few CEs as well. Thank you for keeping it fun and fresh. So thank you, Talia, for sharing that with us. You're, of course, the reason why we do this. So thank you for listening each and every week, and thank you for also taking those CE courses. It's interesting because I also had another message earlier this week, and it was regarding the CEs. So I thought, hey, let's talk about it real quick again on the podcast. This is how the CE thing works. First of all, I want to be very clear about it. It's really state dependent, right? So if you're allowed to take distance learning CEs, this is a perfect situation for you. If your state requires it to be live, then this is unfortunately going to work for you. But so just a refresher, if you have in your podcast app that you also have a place where you can click either on the title or maybe it's the title of the episode. There's a place in there where you can find the show notes. And if you can't find them on there, if it's too hard, you can always go back over to our website, tale2hygienist.com, and find the episode that you're looking for, go into the show notes there. There will be a link for your CE, and that links up to CE Zoom, who we've partnered with to give you guys these free credits. So when you go there, you'll just have to take a test, and the test isn't all that difficult, but it's definitely something that if you've heard the episode, you'll pass. If you haven't, you might not be able to guess your way through it. So make sure that you're checking all that out. Again, thank you, Talia, for that message. If all of you would do us a favor, head over to your podcast app, though, and leave us a message and a rating. That would be awesome. It really does help us stay at the top of the charts for dental podcasting. It might not seem like a big deal, but that's how people find us. And so for us, it really is a big deal. While you're there, make sure you hit the subscribe button and tell your friends that they need to hit the subscribe button too. I was thinking this week, and I don't know if this is going to be something that we're going to continue to do, but I was thinking about starting a segment called This Week in Social Media. And basically what I wanted to do is just share something that I learned or share something that I saw. Because, this podcast really originated from, I think most of you started listening because you saw us on social media. But I think also, this is a podcast for the people, so to speak, right? So I kind of want to focus it on you all, everyone that's trying to help this profession. So we'll give it a few weeks, see how it goes. If you want to give me your feedback on it, let me know if it's a good idea or a bad idea or something that I need to be sharing. Send over an email to andrew@atale2hygienist.com. If you can screenshot the link or something like that, that would be really helpful for me to try and find it. I am a member of most hygiene groups, but I think I've gotten kicked out of a few of them, so I don't know. We'll see about that. So this week in social media, I saw a post in Brown Girl RDH, and it was a picture of a hygienist with a child in the chair. We've seen these a lot, right? But the thing that was unique about this is that there's a bunch of other children right around the chair watching this appointment. And I know that in this day and age, we're all freaked out about COVID and aerosols and infection control. And I'm not trying to minimize that because that's really important. But I want to set that aside, though, also just for a minute, because how many of us have had the opportunity to teach the next generation like this? I think of several of my friends who have gone to schools and taught home care techniques. They've given away toothbrushes and toothpaste, but have any of them really taken the time to promote the profession like this or in a similar way? That next generation is really important. So I'm going to let that sit with you for just a minute, because if you're listening to this podcast, chances are you're one of the elite anyway. You're seeking out more dentistry on top of your dentistry that you already do. And I know that you're trying to do everything that you can to get better. So I guess my message is really for those of you that maybe don't have a direction. Maybe you're thinking, I want to get better. I'm just not really sure how or where I need to go. And maybe this is something that strikes a chord with you. Maybe you can be someone who is fighting for that next generation of dental hygienists. And I apologize, I can't remember the name of the hygienist that posted that amazing message and the sweet picture. But thank you to whoever you are for helping propel this profession forward for the next generation and doing all of the things that you do. It was a very moving and very awesome post. Okay, so stay tuned next week because we have our interview with another fan favorite, Dr. Matt Allen. It will also be Michelle's last interview for ATOTH, so if you could be sure to listen to it, maybe send her a little note of thanks, I think it would really make her heart pretty happy. Okay, that's it. Have a great week, everyone, and enjoy this episode with Sarah and Michelle.
Well, listeners, one of my favorite things to do is to bring return guests back on, but also people that I truly admire and respect in our industry. And we have back on the podcast, Sarah Hornsby. Welcome.
Yay. Thanks for having me. It's been really fun catching up with you before we started recording. So I'm excited for this episode. It's awesome to be back on. And I'm hoping I've got some new and great information for your listeners.
I'm sure you do. And even just as a recap, it's going to be amazing because you've been on before. You did a whole series. It's been 2 years now?
Yeah, I remember that was like January 2020 that we did the series.
Oh my gosh.
And then you had me back January 2021. And so now here we are, January 2022.
Oh my God. That is not planned, y'all. That was not planned.
So funny.
That's so perfect. Well, today what we were going to tackle, because you talk a lot about myofunctional therapy, tongue posture, airway, breath, sleep, all of the jazz, like all of those things that are intertwined. And we had you on for myofunctional series. And then what we wanted to chat about today. So if y'all haven't already, you should definitely go listen to that series. It'll just give you a beautiful foundation for the things that we'll talk about today. Also, follow Sarah and go check out her information. I've taken your Myo Mentor course, which is so incredible. I learned so much and probably
I'm glad you did
more on myself. I did a lot at the beginning, but I'm the worst patient.
I know, we all are. Yeah, no, I'm really glad that you took the class because I'm hoping it kind of gave you like a deep dive perspective into the field and the therapy. And you already knew a ton, but hopefully that was, hopefully it brought some clarity.
Absolutely. And you really dove into the nuances that I did not know about. And with today, what we were going to talk about, because this episode's going to come out in February 2022, where it's Children's Oral Health Awareness Month. And I want to talk about what's going on in the world of myo as far as tongue ties or just ties with children. And how do we as clinicians catch them early? When can we start having these conversations with parents or caregivers? What can we start noticing in the pediatric patients that are possibly in our chair? And like, what does intervention actually look like these days?
Yeah.
So I'm excited.
Yeah, I'm excited too. And I think the first part of the conversation has to be why. Why does it matter? Because that's the hardest thing. And I know the students in my class, they struggle with this a lot with kids because kids don't always have obvious symptoms. So whether it's a tongue tie, a lip tie, or even this new kind of thing we're looking at, buccal ties, you have to think of it as, why does it matter? And so we can look at the basic dental stuff. You have an increased risk for tooth decay and periodontal disease if you're tongue-tied, because you can't clean food from your teeth. You can't do that oral cleansing that we all need while we're eating. So it's like a basic dental reason. Then, next level, it kind of goes to, what about the sleep and breathing issues? So if you can't get your tongue to your palate and breathe through your nose, you're more likely to have sleep and breathing, snoring, sleep apnea type of symptoms. And if parents can't identify, or if the practitioner, you as a hygienist, can't identify these problems, then we have to think about prevention and guiding growth. So if a kid is growing into an adult with their mouth open, mouth breathing, a tongue tie, and low tongue posture, they will have different occlusion, different arch development, different jaw and airway structures compared to if they grew up with their tongue up and their lips closed. And so that's the challenge, is how do you convey that all to a parent who is like, my kids are fine. They're tongue-tied, I'm tongue-tied. Why does it matter? They don't have any problems. They seem fine. So I think if you as a hygienist can understand the why, and we can break that down, further throughout this, that will help when it comes to talking about the actual issue. Does that make sense?
Absolutely. And you just brought up like the self-cleansing or inability to self-cleanse, and how that, and the decay rate. And I know this is a child, we're talking children, pediatric, but I had an adult in my chair a few months ago. And this is why I'm like, we have to find these sooner. This gentleman was going to lose his tooth because there was yet again residual, like a recurring decay. He already had class 5. He had already just a pretty decent gingival inflammation. And when I was like, teaching him about brushing, how can we get back up there? I was like, my favorite thing to do, I always call it the tongue test. And I've taught this since the beginning of my world in dental hygiene, where I'm like, I always get my tongue and I like do this. That feels clean. That feels clean. And I was like, put your tongue up there. And he couldn't put his tongue up there. Yeah. He could not put his tongue up there. And I was like, as if I didn't need another reason to catch these ties earlier. Like, what a perfect example of how this will create long-term issues.
So many issues. Yeah. So if you're a tongue-tied kid and you spend your whole life not able to, touch your molars with your tongue, and your mouth breathing, that changes the pH, it changes the oral microbiome. I mean, so you've got so much stacked against you in terms of just dental health. And so I always kind of say, even if you don't want to get into the airway and breathing and sleep, which I think is actually the most important aspect, just look at it through a strictly dental lens, and you can't avoid the implications of these myofunctional issues on periodontal disease and caries. And so just that alone should be reason for us to be looking at this a lot closer in dentistry.
Agreed. So after the why, how do we tackle this topic?
Yeah, so I think understanding that we've had an evolution of grading scales is a big part of it. So I talk about this a lot in my lectures, but basically we all are taught in school, if you remember or not, that's a different story, but we learn the Kotlow free tongue measurement grading scale. And that's basically looking at where does the frenum, the lingual frenum, insert into the body of the tongue, and what is the distance from that frenum insertion point to the tip of the tongue. And if that's greater than 16 millimeters, you're quote unquote fine. And so that works. That's what we all learned. It's in every textbook. ENTs recognize it. Pediatricians recognize it. But in the field of oral-facial myofunctional therapy, we've evolved beyond that. So we're looking at the function of the tongue, and there's a way to measure the function for the anterior range of motion of the tongue and the posterior range of motion for the tongue. So that's where we're almost speaking different languages in my world and in kind of mainstream dentistry and healthcare. Because if you're just looking at how far can you stick out your tongue or how much free tongue do you have, you're not going to understand why someone like me would recommend a tongue tie release for a patient who has like a pretty good free tongue score. And so Kotlow free tongue measurement has really evolved to something that we're calling the tongue range of motion ratio. And that was only a study that was published in 2017. The most recent one where I was talking about the posterior tongue mobility, that was only published in 2021. So unless you're really in the know and in this field, you're not going to know about these grading scales. And I think that conversation is so important when you're trying to refer to doctors and work with doctors who are going to do surgeries. Is you want to speak their language and help the parents understand. If you take your child to this pediatrician, they will probably tell you your child is fine. And so here's what I see, and here's kind of, the explanation of this older model that we've evolved beyond. And so don't be surprised if your pediatrician doesn't see this as an issue. And that's unfortunate, but I think it's really helpful for parents to understand that we speak different languages depending on, our training. So.
That's such a good point. Because I mean, do you feel like it's getting better? But once upon a time, if I sent a child to have a tongue tie assessment, or if I bring up the tongue tie, the lactation specialist or the pediatrician was like, they're fine.
Yeah,
they're fine.
It's getting better.
Latching.
But
okay,
yeah, so sometimes you can look at symptoms and those are going to be the obvious. So it's like, okay, if you're a baby and you can't breastfeed, maybe now we can explore the tongue tie, lip tie connection. But there's a lot of tongue tied and lip tied babies who actually do breastfeed quote unquote fine because they're gaining weight. So if weight gain is the only metric you're looking at, then a lot of babies are going to be, like I said, quote unquote fine. But if you're looking at function and how is that setting them up for dental and oral and airway development, they're not fine. But that's the bigger picture message that, we don't have that as part of the standard of care. And so it's a bigger battle, I guess, in a lot of ways. So yeah, we can look at symptoms like breastfeeding issues with weight gain. You can look at speech issues with children, but there's a lot of kids with myofunctional issues who speak perfectly. And so most of the people that I work with don't have speech issues. So, even it's like a symptom that can get people's attention, but it still, might get missed. Then there's the snoring and teeth grinding and more of the behavior type ADHD type of symptoms that you can see in kids, which are like very clearly linked to breathing issues. Through research, like we know this hands down. There's no question, there's no doubt. Kids who have breathing issues and sleep issues, they have behavior issues a lot of times that look like ADD or ADHD. So these are things that are red flags to me when kids are struggling in school or with emotional control. My first thought is, what's going on with their breathing and their airway? Can they breathe through their nose? How are they sleeping? And so, there's a lot of stuff going on there that we can unpack, whatever you want to focus on.
Well, I guess so we're not seeing babies, but we're seeing the moms after they have had their pregnancy and birthed this child. And do you feel like that's where the conversation starts? Like, how is it going with the baby? How is it? I mean, or is that like even too much? Maybe we need to focus on the mom.
It depends. And it's so hard because, some parents are going to be really open. Like some moms are going to want to, do everything and talk about everything. And some moms probably feel overwhelmed. Like, why does everyone have advice for me? Why is everyone telling me what to do? Yeah. I mean, ideally, yeah, you would probably talk to like a pregnant mom about the challenges around lip and tongue ties. And especially if you look in their mouth and you see that they have a restricted lingual freedom, then you can say, hey, these things that we see in you, it's very likely that your baby might have some of these symptoms as well. And it might not be affecting them as an infant, but, a lot of parents connect with, especially if they've had struggles. So a lot of my adult patients, they're like, I need my kids to do this now because I don't want them to go through what I've gone through with my teeth and my ortho and my pain, like TMD issues and stuff like that. So yeah, a lot of times the parents who identify with the symptoms really want their kids to get the treatment. The challenge is when the parents are like, I'm fine, I don't have issues. And I see every red flag under the sun, but they don't identify with it, So it depends on where they're at on that spectrum.
Well, that's what I was curious about as far as if I'm seeing this in the mom, and if I know, because I have noticed this, tongue ties in moms or lip ties, these buccal frenum attachments. I think that's a beautiful place to start, or even ask them, like, what is your partner's situation? Do you know if they also have any issues? Because the likelihood that your child has that is pretty high.
Yeah, for sure. Two tongue-tied parents will definitely lead to a tongue-tied baby in most cases. I mean, for sure. So I don't know if it's like, if you could choose a specific tongue-tied gene, it is hereditary, just like any other trait, like blue eyes or brown eyes. Like, it's hereditary. It runs in families. It's also, there's epigenetic influences that, you know, we could dive into and talk about more, but there's a lot of reasons that people suspect, why are there so many tongue ties and why are there so many lip ties? I don't think we know the answer, but there's a greater awareness for sure. And I think we're finally understanding at this point what the implications are, and that, you know, it could be a small problem or not even a problem in your 6-year-old, but by the time you're 26 or 36 or 46, it will be an issue. So it's more of a when will it be a problem versus will it be a problem.
And that's so true. And I can speak it only on my case and what my mom has said in the past, because I definitely have a little bit of a tongue tie. I have some tongue posture issues, and that has all resulted in me having my jaw broken and moved.
Yeah.
And now I have condylar degeneration. And my mom always is like, I wish I had known. I wish I had like made that easier for you. Like, and it's like, we didn't know what we didn't know. God, I wish somebody had given me myofunctional therapy at 8 before they put me in, 8 years of ortho and then broke my jaw. Like, that would have been fabulous. But now we know these things. And so if we can get ahead of it and prevent the crap that I went through, like, that would be, definitely. I'm sure every parent would want that for their child.
I think so. And I think as hygienists, we resonate with prevention. Like, why wait till there's a big issue? Let's catch it early. And so it's the same message that, we talk about as hygienists. Let's catch these things before there's a problem and like alter the path, optimize the growth and breathing of this child, so now they don't have these bigger problems down the road. And so the challenge is explaining this. I think what I notice through my students is they get these concepts. It's the communication around patient education that is the most challenging aspect of this field. And so the good news is these days there's so much helpful information online. Go back over 5 years ago, not even 5 years ago, it was hard to find information on this stuff. Now you can Google tongue tie, mouth breathing, sleep apnea, and there's research, there's TikTok videos, there's, YouTube videos. There's so much information now that I tend to put it back on the parent and say, I see this as an issue, but look online, go read about it, learn for yourself, because the parent has to resonate with it. Otherwise, they're not going to it's hard. It's hard to do this therapy with a 6-year-old, 8-year-old, 10-year-old. It takes dedication and work. It's like homework. You have to meet with a therapist. You have to do the exercises. So I want the parent to truly understand and value how important it is, and know and understand the bigger picture implications if they don't do it. Because otherwise, it's miserable for everyone.
Do you feel like a lot of the or it's probably a culmination of it all, but the not understanding it, no one's ever talked about it before, or does it feel just so overwhelming, the treatment, the therapy, and in some cases surgery? Do you think
it's both? It's definitely both. And the challenge too is that dentistry isn't set up to handle these types of treatments, so the doctors are kind of scrambling, like, okay, they need a tongue tie surgery and I don't know how to do that. Who do we refer to? Okay, they need ortho because there's not space in the mouth because we've got these narrow palates and crowding. Okay, do I do the ortho or do we refer for that? Now there's the hygienist or myofunctional therapist like me who's like, well, they need this therapy. So it's hard for practitioners to know where to start, what to do first. Where do we do the exercises and the therapy, or the ortho first, And so we don't have standardized protocols around these things at all. And so that's challenging. Like, we're healthcare providers and we get all of these problems and we understand it. And then the parents are there like, okay, no one's ever told me about this. Like you said, my pediatrician says I'm fine. The other dentist I went to said I'm fine. They never brought this up. Now you're bringing it up out of nowhere, and it seems like a big deal, but like if it's such a big deal, why has no one told me? And then, okay, wait a minute, it's this much money, and oh geez, it's also this much effort. It's going to take 8 months of, meeting with a therapist and 12 sessions. And, so between the cost, the coordination of the professionals, the time involved, I just talking about it, I'm like, geez, I'm amazed anyone does it. But that's the bigger picture. I can convey how important it is so that parents do that, and they understand it, they value it, and they want to do it. And that's, once it becomes a more mainstream topic, I know that at some point, I just don't know when, it's going to be just the same conversation as parents have on like a soccer field, like, oh, who's your orthodontist? It's going to be, who's your myofunctional therapist?
Myofunctional therapist. What a dream.
Yeah. It will be that way. I don't know if that's 5 years, 10 years, 20 years, but just as many kids who need ortho, they all need myofunctional therapy.
I agree.
So it's not that there's not a demand, it's that people don't see it yet, it's not that there's not a need. There's a huge need for it. We just don't have the systems for setting it up, and we don't, even as healthcare providers, we don't connect the dots as a whole. So there's a few people out there who do, like you, me, people listening to this, the dentists I work with, but I would say that's like 1% of what we need,
Yeah, I agree. But that whole, I think, conversation, that's more once the child has developed and created, there's dysfunction already, right? But if we catch it early, would we have that same kind of I know tongue tie release.
Yeah.
But
I'm talking like 6-year-olds,
would it be Yeah. Okay. So I was like, is it an easier process if we catch it sooner?
If you could catch it when they're like an infant and they're breastfeeding, that would be ideal. And then if you're able to track that development and, make sure they're working with, the right specialists, the challenge with releasing the tongue tie as an infant is they have to get the lactation support. They have to do the stretches, which is, it's hard, all of it's hard. So there's still a chance, even if a baby has a tongue tie released, there's still a chance that that child might be mouth breathing or still have some degree of frenum restriction when they're 3. And so if you could address it then, awesome. If you could, so parents have to realize, I think, that until they're done growing, you've got to really watch the stuff and monitor it. And so I kind of joke about it, but I'm like, just the same way that as parents, you've got to be like, okay, turn the lights off, eat your vegetables. You can't have ice cream for dinner, sit up straight, do your homework. There's all these things that we have to constantly remind kids to do. The same thing with close your mouth, breathe through your nose, where's your tongue? Like these are lifelong childhood conversations. So what I try to convey to parents when they're doing therapy with me is this isn't just, I'm a magical therapist, I'm going to change all these things, and then boom, your kid's fixed forever. As they go through all phases of growth and development, there's chances for them to, I don't want to say fully relapse, but, if they do therapy when they're 6 and when they're 12, they have like a really bad cold and get giant tonsils and start mouth breathing, then, they can relapse. So it's just a constant, parents have to be keeping an eye on it. Kids have to learn to develop awareness around it. And, it's like lifelong good habits, like eating healthy and all that stuff, exercising. So it's just something we don't talk about. Or brushing your teeth. I'm always like, we talk about how important it is for kids to brush their teeth and learn to floss, but we never talk about how important it is to make sure you can blow your nose and clean your nose and breathe through your nose. That should just be a conversation we all have, right?
I agree. Oh my gosh, that's so true. But also, parenting's hard. There's so much, and so I can understand where it feels overwhelming. But when you go back to that why of what happens when you have this dysfunction and what that creates for the long term, for a developing human. Because as you mentioned earlier, the more important part is the sleeping and the breathing. And when the child isn't doing those things, how it affects how their face grows and their body grows and their mind and all
their
of it.
Mental health, their emotional state, it's stress on the body. Basically when you're mouth breathing, your body's in a state of fight or flight. So you're in this sympathetic nervous system, anxiety, stress mode all the time. And that's not fun. Like, you don't want, I think if a parent understands that their kid is in like fight flight all the time, that's, that's stressful. And so no wonder they have behavioral issues. No wonder they have sleep issues. So, your stress system isn't meant to be activated like that constantly. So yeah, I think it's just, if you can help parents understand they want to do it and they'll put in the effort, and then they'll, do the best they can. So.
And I think the cool part about this therapy, and if anything, you were doing this before the pandemic, but 2020 taught us that we can do most things virtually.
Yeah. Oh my gosh. So that's
that's the cool
interesting. Part. Yeah. Yeah. It's so accepted now. Actually, I love it because I've been doing therapy online since 2015. And it was always this weird, like, are you sure it works? And what, how do you see people? And, it was always this weird mystery type of situation. What's Zoom? Like, I remember having to explain Zoom so many times to people. And now it's just like, okay, people accept it. And like, oh yeah, that works too. So I feel in a lot of ways, it's so funny. I feel very validated by all of the, like, now everything's online. Yep. For years I've been like, why can't I do that online? Now I can.
Now we can. And so my hope is that parents are more accepting of the treatment and recommendations, because it isn't packing the kid in the car and going to this appointment for the next hour. And now I had to take off from school and I had to take off from work. And
exactly. The convenience factor is huge. Mm-hmm.
Huge. So I would love to know, like, could you speak a little bit to what if we catch the baby, right? Like the mom is like, yes, I'm having issues with lactation or them latching, or I noticed their tongue or their mouth breathing, but they seem to latch okay. What would it look like for the steps of like treatment for that infant?
I think the biggest thing is that it's multifaceted. And so the big thing for babies is actually body work, like cranial sacral therapy type of, it's so cute. It's like baby energy massage. I don't even know how to describe it, but it's very cool because that actually it's working on fascia. It's working on like cranial strains. I don't even fully understand all this stuff, but just that alone can help a lot of babies with latching and breastfeeding. So I think when you're taking kind of a more full body approach, addressing that as part of the surgery is actually going to make the surgery more effective. Okay. So I think the challenge that we have with a lot of the infant tongue tie stuff that's happening is it's almost like every baby's getting their tongue tie released now. And the challenge with that is when it doesn't work, then we don't know why. And so it's because yes, maybe they had a tongue tie, but there's other stuff going on. So they probably needed body work or they needed lactation support. So that's really, there's 3 areas that really you can look at: the structure of the tongue, the function of the tongue, and then like behavior. And that can be just, habits around, I guess, in babies, feeding patterns that they get into. With older kids, it'd be like thumb sucking or things like, pacifiers, sippy cups, all of those type of things. So you have to address all the 3 components: structure, function, and behavior, and then you're going to address the problem. So if we only do surgery, we're not necessarily helping function and behavior. And so it applies to babies as well. But yeah, I think that's a big part of it is releasing the tongue tie, but then understanding the function too.
So good. And then when they actually go through the surgical process, do you know what that looks like these days? Because I know that we've gotten very cool lasers in our profession. What's the process there? I
think so. I know I've learned a lot about lasers, and so I think the laser is probably the best option. But the type of laser is important. From what I understand, working with Light Scalpel, which I'll give them a little plug, they're a Seattle-based company, and they, Dr. Peter Vitrick is like literally a laser physicist, and I've learned a ton from him. And I didn't know the difference between like a diode laser and a CO2 laser, for example. And so I think the CO2 is the standard of care. It's a lot more expensive, and so a lot of doctors will use the diode, but diode is not great on infants. There's a lot of people who do it. I don't want to like make anybody feel bad, but I mean, it's basically just a hot glass tip, and it creates a lot more scarring and trauma than the actual CO2 laser would. So I think especially in infants, use the CO2. It's a lot less painful in the recovery, and there's less inflammation. It's a lot faster. And so if you have the option, I would find a provider who has a CO2 laser and who's experienced with infants.
That's great. And then I know there's some stretching and things that would happen afterwards.
Yes. Yeah, I should give a shout out to a couple people. Dr. Chelsea Pinto from the Breathe Institute, she has a great course on this stuff if anyone's interested in babies. Like, they do so much like before and after stuff. I don't work with babies personally, so I'm not involved in a lot of that hands-on with like the body work and the lactation and the cranial sacral and, you know, the stretches. But basically the idea is to make the stretches fun, to, you know, they're painful. So parents have to understand like, okay, your baby's going to cry, but it's okay. Like, you make it supportive and fun. There's Dr. Richard Baxter's got a great course on this. He's the doctor who wrote the book Tongue Tied. He's based in Alabama. And then Michelle Emanuel has a lot of stuff on tummy time and some of the stretches that can help with infants too. So there's a lot of resources for babies. And if anyone's interested in getting into the infant side of things, I would say find a doctor who's doing the infant frenectomies and try to, you know, work alongside and support them and, you know, get training that's appropriate for that setting.
That's great. And then is it harder as they get older? Because like, let's say it's a 2-year-old. Now their first, maybe even 1-year-old, whenever the parent decides to bring the peds child into the dental appointment, 1 or 2 or 3, like, is that harder?
It gets harder.
What are we looking at?
Yeah. So when babies are small enough to be swaddled, that's one thing. You can wrap them up. They're going to cry and they're going to have it be done. Once they get bigger and you can't really swaddle them, and they're also like still too young to do any type of like myofunctional therapy, especially if they're getting teeth, and it's going to be hard to get your fingers in there to actually do stretches. There's kind of this in-between age where I would say between like 1 and 3, where sometimes I think the parents need to decide, is it worth doing this now and realizing that it might reattach to some degree and we might have to do it again when they're 8 or 9 and able to actually do exercises. If it's a really bad tongue tie, like if it's a grade 4, which I can go into that grading scale that I'm mentioning right now, but if it's a really like tip to the tongue, fully ankylosed tongue tie, then I would say, yeah, it's worth releasing whatever you can and knowing that you might have to, there's a high chance you're gonna have to go back and do it again when they're older. So I think if you have that conversation with parents and they understand, great, it's fine. If you have the option, like some parents are comfortable with this and prefer it, some would rather avoid it, but if they can be sedated and actually get sutures in the tongue, the sutures will help with the healing and it will heal a lot. They don't have to do stretches basically because the sutures work with primary intention, wound healing versus secondary intention, where they have to manually keep the wound open to heal. It's a lot better. So these days, suturing is really the modern way to do tongue tie surgery. So whether you use a laser or use scissors or whatever in adults, suturing the wound closed is critical for optimal results. And that's something that for decades we never did in dentistry until like the last 3 years. And now we're like,
I didn't
we should
realize
suture.
That's what we were doing now.
Yeah. A lot of it's because of Dr. Zaghi and the Breathe Institute and the latest research that's coming out. But if you think about it, it's kind of common sense. Like, what other part of your body would you ever do surgery on and not close up the wound?
Yeah.
Like, isn't that weird? If you had a mole removed, you'd want them to close up that wound. If you had a gash on your arm or something, like, you'd want the wound closed. It heals better. The scar is smaller, so it heals faster. So there's less granulation tissue. Like, the whole healing process is just so much better when you pull, like, so they do the surgery, there's a diamond shape and they pull the outer edges together and now you have just this nice clean line. And, I think the reason we probably never did that before was because we never were doing myofunctional therapy before. So the tongue was really weak and floppy and like probably couldn't even, get sutures under there. So if the tongue is toned and like, prepared, then you're going to have optimal function, optimal surgical results, and optimal healing of the wound. So yeah, I mean, my recommendation is find somebody who's comfortable suturing, find somebody who's done a lot of these procedures where they understand the function and not just, releasing the tongue tie. I'm biased, but I always recommend the Breathe Institute, getting training under Dr. Zaghi because he's teaching these techniques. He's an ENT and I work closely with them. And so I trust that any doctor who's gone through his course, they understand function, they understand the bigger picture, and that's what's important to me. So I want to refer my patients to a surgeon who understands my goals of nasal breathing and getting the tongue to the palate and, suturing the wound closed for optimal healing and all that.
I would love to talk about the classifications that you were describing.
Yeah.
1 through 4,
sure.
Is that what you said?
Yeah, so we have a classification system where it's the tongue range of motion. And so we're looking at if the anterior part of your tongue, and everyone will have to kind of envision this because we can see each other, but I know if you're listening, you can't. So if you open your mouth as wide as you can comfortably, not like pain, don't cause pain, that would be the first measurement that you take. So your maximum or your comfortable mouth opening. So that's the first. Now you put the tip of your tongue up to your incisive papilla and you take that second measurement. So now you divide the tongue up by the first measurement and it gives you a percentage. And that gives you let's say 80% or 10% or whatever. So obviously the higher the number, the better. That means your tongue can go up more. You have a better range of motion. So if your tongue range of motion is 80% or more, that's grade 1. If it's 50 to 80%, it's grade 2. If it's under 50%, that's grade 3. If it's under 25%, that's grade 4. So I've got a great visual. You could, I don't know if people want to see it. We could find a way to share it with anyone who's interested. But yeah, grade 1 is normal or fine. Grade 2 is, for the most part, what most of the population is. And it could be an issue, but it could be fine. Grade 3, once we get to that 50% cutoff, we know you have a problem. You need surgery. You cannot have proper function with a grade 3 or grade 4 tongue tie. So grade 2 is kind of the gray zone where we don't necessarily know, but for sure the grade 3s and grade 4s, you've got to do something about that.
Okay. Well, that's pretty easy. And I feel like that would be okay to do with children even.
And you can eyeball it, to be honest.
Yeah.
Yeah, you don't need to get those exact measurements. I mean, if you're familiar with the system and you can kind of, you learn it, the measurements are really more for research. And that's where we need strict hardcore numbers. But clinically, it's the same thing as looking at tonsil size. You can kind of say, oh, that looks like a grade 2, maybe grade 3 tonsil, or looking at, I don't know, what do you eyeball in dentistry, clinical hygiene?
Maybe.
we do it with,
caries or something.
Yeah. Maybe, I don't know.
Oh, Mallampati
score. You're not getting out anything to measure how much is the soft palate hanging down or whatever. So yeah, I mean, I can look at somebody and say that looks like a grade 2 or that looks like a grade 4, so learning that can make it easier. And then you always know, 50% is the cutoff. If you're below that, you definitely need to do the surgery. If you're above that, you can probably get function without it, but let's see.
Well, I also think that a lot of us are not including that in our assessment, even Mallampatis, the tonsil size, all of the tongue. I think that would be great if you're listening to this and you have a template that you use for your exams.
Yes.
Let's add that. Let's go ahead and add that information. And I think you'll really start to notice how many people are struggling with
oh my gosh. Yeah.
attachment issues.
For sure. Yeah, I think all of those things are helpful. And, all of the things that we see in kids, and I know this topic is focused on kids, everything that we see in kids, it's there in our adult patients as well. In kids, we're in the age where we can actually prevent stuff. So our adult patients, they're done growing, they're kind of, it is what it is. I will say though, unaddressed myofunctional issues for decades, they don't go away. So, treating it when you're 30 is much better than waiting until you're 50. But when you're a kid, that's where you really have the opportunity to not just change the function, but also the structure through guiding growth.
I guess I'm also curious about teenagers. When is it so 1 to 3, maybe we make that decision. Then we get into 3 to any age?
Kind of
3
like
to
mixed
18?
dentition age.
Okay.
Yeah, I think there's some, I'm not gonna like butcher this, but it's something like 70% of craniofacial growth and development is completed by age 7, or it's like 90% by age 9 or something like that.
Okay.
So our jaws and our faces are really not done growing, but they're almost done growing pretty early in life. So it's not too late for teenagers, but they're kind of, they're on the, I guess, the final legs of their growth, but
Right.
it's still better to treat stuff. I mean, the sooner you identify the symptoms and recognize these as problems and get it treated, the better. So teenagers, I think, are in that stage where if they haven't had ortho, they're going to be treated more like an adult. The early intervention philosophy with orthodontics is really what I try to pair patients with. I know that the challenge with ortho is burnout and compliance, but if you can get expansion in kids young enough to set them up for having better tongue space and tongue function and breathing, it's better. So, I mean, my philosophy around this has changed so much. Like I used to treat, parents would come to me and they'd have a 6-year-old and they'd want to do the therapy, and I would see that they had a lot of crowding in their baby teeth, and I would be like, okay, let's do the therapy. Now I feel like I'm actually stealing their time and, their time growing. So I would rather have them spend their money and time of growth years working with an orthodontist who can really catch them up. Because if you think about a kid who's been mouth breathing or tongue tied since birth and now they're 6, they're behind where they actually should be in terms of growth and development. So we know that baby teeth should all have, what do they call it, primate spacing? Like you should be able to fit like a dime or a nickel between every single primary tooth, and that never happens anymore. So if you see baby teeth that are touching or crowding, that kid needs growth guidance. They need an appliance, they need expansion, they need something more than just what I can do. And so I would rather have them, go into overdrive on like ortho than see me. They still need to see me, but I would rather have them go see the orthodontist first, come back, and we'll work on the lips together, tongue up, breathing through the nose, or at the same time. That just might be too much for the family.
I was going to say, like, what a dream to have it all happening at the same time when you have an orthodontist that would be ideal. That has a myo.
Yes. That would be ideal. So, yeah. So, yeah, I mean, it's not too late for teenagers. I think the best age is young, but it's that balance of like, when are they too young to do exercises? When are they too young to be compliant? When are they old enough to be compliant, do exercises, but like they're not growing as much? So it's just, you do it when you can, and that's really it.
So in our final like moments together, I'm sure there'll be hygienists that hear this and they're like, okay, got it. I will start making note of this. I will have these conversations. But then they're probably going to end up like I did, where I was like, I know too much now, and I don't know what to do with these patients.
Exactly.
Like, where do I send them? I'm seeing the ties. I'm seeing the myofunctional issues. I'm seeing the decay. I'm seeing the mouth breathing. The parents are noting these things. I don't have a resource now because no one in my area does myofunctional, or even like there's a dentist that does release and they aren't including myo with it. And like, what do I do now?
Yeah. I mean, I mentioned it earlier, but you can always turn to online resources and online education, and just sometimes a really motivated parent will drive to the next state over or fly somewhere, or if they really resonate and they're like, wow, this is my kid, and you can't find the right support, then you can work with a therapist online. You can go see a tongue tie specialist, a couple hours away if you have to. So I'm not saying that's ideal. I wish we didn't have to do that, but I think as a hygienist identifying these symptoms, the first thing I would say is try to look up, see who's a myofunctional therapist in your area. They might be a speech pathologist, they might be a hygienist, but they will have a network of people that they've probably looked up who are more in the know of all of these things. Or you can always get the training yourself. That's always an option. But then you're still going to have the same networking challenges. And I think the therapy is not challenging. It's actually building that team. I think that's where the majority of hygienists and dentists who get into tongue tie, myofunctional, airway, sleep, breathing, that whole world, they all struggle to build their network and find their team. And once you have that, I mean, it's amazing. But finding all the people can be hard. But the good news is they're all looking for each other. So if you're a myofunctional therapist, there are dentists and surgeons and people looking for you too. Like, I need you to complete this piece of my puzzle, you know? So that's changing a lot. And I mean, I've got over 600 graduates in my program alone. So, you know, people can reach out to me, ask, do you have someone in Chicago? Do you have someone wherever? We've got people in every state. So it doesn't mean they're close, but at least they're in your state and they might know somebody who's closer to you in your city or town or whatever.
Oh, that's good. And you're right. Like, there's a lot of online resources. I've sent them to your YouTube page.
Thank you.
To learn myo, just to, maybe it's just the stretches, it's the exercises, the tongue up and opening the mouth, all of the little things that at least I can say, this is a good attempt.
Yeah.
And you mentioned it earlier, but like, there are people on Instagram, there's people on TikTok, like you could follow these people and just start
and
working
just learn
with,
more.
And find your favorites and then tell your patients about them.
Well, I always tell people, I'm like, I would love for you to be able to do this without me. You know, if you can change your habits, if you can work on these things, just develop like super good awareness. And if you can do it on your own and you don't need to pay a therapist, like, that's the best. I mean, if you need help, I'm here. But hey, look at all these resources. Try to figure it out on your own. If you can, great. Save yourself the money. But it's hard, and I know that. A lot of it's really challenging. And some people do just need that support and hand-holding. And so I'm not trying to like undermine the field by doing that. But hey, I just want people to be healthy and, you know, get the treatment. So if they try on their own and they do the best they can, and then they finally reach out, they're going to be good patients because they'll be like, I tried this on my own for 6 months. I struggled. I still don't get it. I want to work with a professional. So, I mean, I think it's a win-win either way. You know, if they get the help and they do it with me, cool. If they figure it out on their own and they don't need me, then hey, they're still healthier and better for it, you know?
So true. And how can people find more info from you or connect with you?
You can find me on Facebook, Instagram. I have a YouTube channel. I haven't got onto TikTok yet. You're ahead of me, Michelle. Maybe you'll have to teach me. But yeah, I have a couple websites you can go to. Myfaceology.com is more directed towards patients. I have myomentor.com. That's directed towards hygienists, and it's more about my training course, and dentists as well. I actually have had probably over 50 dentists go through my course. Actually, probably more like 60 or 70 now at this point. But what's happening these days is a lot of dental offices are signing up as teams, which I find very encouraging, because that means that this can be implemented more holistically in a practice versus just a hygienist getting trained and then trying to figure out, how do I do this? You know, so I think that's a really good sign. So sarahkhornsby.com, myomentor.com, myfaceology.com are all great resources. So, and I'm making changes to all these websites and hopefully combining them into one at some point, but you never know. On my to-do list.
Because I am too, and it is not easy.
It's hard. Yeah. It is hard. I'm like, how did I end up with 3 websites? But, you know, it just happens. So.
It does happen. Well, thank you again for a third January in a row of doing this podcast with me. And I love learning from you, and thank you for your expertise and being such a resource to us. Yeah.
Thank you so much for having me and giving me a platform to share this stuff. I think it's so important to reach the hygienists. I think they can really create change in their offices a lot of times. And, you know, if they can't, they can go out and learn this stuff on their own and talk to patients no matter what. Even if it's just helping friends and family, I think learning this stuff is the future of dentistry, and it's important for all of us. And so for anyone who's interested in, you know, kind of being, I guess, on the forefront of it, I'm happy to inspire that in anyone who's listening. So, yeah.
Thank you.